In this brief presentation, I would like to review what is meant by the term arthritis, how it is measured on X-ray, and lastly, how is it treated. First, however, a brief discussion of anatomic terms would be helpful. It is important to use the words cartilage and meniscus correctly. The meniscus are two washer-shaped rings that cushion the joint and are attached to both sides of the knee. The term cartilage, on the other hand, refers to a smooth, white linoleum-like layer which covers and protects the underlying bone and allows for painless joint motion. Cartilage injury actually refers to a progressive wearing away or sudden traumatic damage to the cartilage layer. Cartilage injury, by definition, is arthritis. Since both meniscal tears and arthritis are all too often found together in painful knees, the correct use of the word cartilage and meniscus is important to avoid confusion. Many of us think of arthritic pain as severe, unremitting, almost continual pain. In fact, arthritis exists on a long continuum. What is perhaps the most perplexing to middle-aged patients is the fact that injury or sudden onset of pain is not clearly indicative of meniscal injury. Progressive arthritic damage to the cartilage layer leaves the knee more vulnerable to shear and rotational stress. Many individuals first become aware of arthritic knee pain suddenly as a result of previously well-tolerated activity or following injury. If one were to take the time to discuss knee pain with someone about to undergo knee replacement surgery, they would most likely describe their experience over the preceding decades as marked by periods of pain interspaced with long periods of well-being. At this point, I would like to review with you how arthritis is measured or quantified in different individuals. Standing X-rays can be very helpful in determining the presence of significant arthritic changes. When you stand, the bones of the knee are pressed together, producing a bone-cartilage-bone construct. Since X-rays visualize only bone and not cartilage, the height of the cartilage layer remains invisible. This produces a clear space between the bones of the knee. This clear space, or joint space, directly reflects the height of the underlying cartilage layers. As the cartilage surfaces wear away and become thinner, the bones on the standing X-ray appears closer together. In other words, the joint space narrows. The degree of narrowing reflects the amount of arthritic damage to the knee. The X-ray on the right reflects moderate arthritis, in this case a loss of 50% of the normal joint height. Severe or end-stage arthritis occurs when the cartilage layers have been entirely worn down, leaving nothing to hold the bones of the joint apart. Not surprisingly, we call this bone-on-bone arthritis. Unfortunately, standing X-rays, although certainly helpful, cannot identify arthritis until degenerative changes become fairly advanced. Areas of exposed bone surrounded by normal articular cartilage is called focal arthritis. Focal arthritis will not be detected on standing films as the surrounding articular cartilage remains of normal height. These pillars of normal cartilage maintain the height of the joint space even in the face of severe central cartilage loss. Treatment of osteoarthritis may be conservative or surgical, depending upon the severity of symptoms. Treatment includes anti-inflammatory medication, occasionally a cortisone injection, gentle strengthening, and time. More controversial treatments of osteoarthritis include Synvisc, a gelatinous fluid which is injected into the knee over a 3-week period in an effort to add lubrication to the arthritic joint. glucosamine or cosamine, and lastly, arthroscopic debridement, also called scraping, shaving, or cleaning out. Over the past 5 years, it has been increasingly obvious that arthroscopic treatment has little beneficial effect on relieving the pain of knee arthritis. If, after a period of conservative treatment, pain and limitations persist, marked by limited ability to walk distances, night pain, pain at rest, knee replacement surgery is then generally considered. Though it is not the purpose of this presentation to discuss knee replacement, in short, the procedure resurfaces the knee with metal and polyethylene, allowing mobilization and eliminating pain. Depicted in this slide are the steps in knee replacement surgery and examples of the resurfacing components. In this slide are depicted first, a knee with end-stage medial osteoarthritis, a unicondylar or half knee replacement, and a full total knee replacement. Frequently, patients ask when it is appropriate to consider joint replacement surgery. Most simply stated, joint replacement is undertaken when pain and loss of the ability to ambulate have reached the point where quality of life is significantly diminished. Although this may seem difficult in the abstract, it has been my experience that most patients inherently know when they have reached that point. I hope this has been of interest and beneficial to you in regard to understanding what knee arthritis is, how it is measured, and what are your treatment options. Thank you.